It's Steve Bates of the BIA, welcoming you to this webinar on antimicrobial resistance, overcoming the risk to global health. We're going to go for about 40 minutes today, and this is the agenda. I hope I can give a brief introduction to what the BIA is doing in this area. We have three great member companies ready to tell what they're doing in this space. We've done a charity partner, and I hope there's time for questions and discussion. So, move forward. Has had an informal working group focused on antimicrobial resistance for the last 18 months or so, and I've been working at all levels to try and make sure that the policy environment for companies and people looking to develop new things to tackle this global threat have a benign policy environment, a supportive policy environment to do this in. At global level, with the International Confederation of Biotech Associations, the ICBA, to ensure that this is the global agenda, and particularly at events like BIO. I take the lead for this at Europa Bio, which is at a European level. Many companies in Europe work with. We're engaged with the O'Neill review, the review by Jim O'Neill into the global challenge. We're on the industry government AMR working group, SMEs, and work closely with the APPI, the Association of British Industry. Their partner, who you'll hear from Colin later in this webinar, is Antibiotic Research UK, and we work with BIO now, the membership organisation in the northwest of England, in their Bio Effect conference, which this year will be at Audley Park on the 10th of November. So hopefully that gives you the spread of where we're at. Our key issues is ensuring that small and medium-sized enterprise expertise in this area is shown and that particular voice is heard. I hope I've done a job in coordinating the community involved in this space, and this webinar is another example of that. I suppose the key thing from a small company perspective as well as a large company perspective is the challenge of the reimbursement model and how what should be paid for these studies coming through, and that's obviously at the centre of the O'Neill work and others. So that's probably the core thing we've been working on, and aligning ourselves with Dame Sally Davis in her deliver the UK government strategy, which is to ensure that other countries and other parts of the world have antimicrobial resistance as a global issue. And I think quite successful in internationalising this, and with that is part of the UK strategy. We're supporting the UK government strategy through. So what things have we been up to? Perhaps next slide. Commons Science and Technology Select Committee on AMR inquiry recently. We've sent some thoughts, both formally in writing and informally through discussions, to Jim O'Neill. We work closely with BIO to develop sessions at BIO in last month, inspired media coverage, and informed that coverage. I think particularly interesting is the script microsite on AMR, which is a good source of information. I could summarize what we've done in a simple picture. I think you can see in here, you can see Neil of Redex, who is in a cab on his way to us now. Williams, who is on the line of Discover, and Jim O'Neill, the economist who is now Treasury Minister, who's leading the O'Neill review, into chatting informally in terms of a session that we helped inspire BIO last month. And I think you can show that this has put us at the heart of the discussion. So next, let's just give you a little bit of what we're next in terms of the policy environment. This is the 7 sub-reports that the O'Neill review plan to do before they do their final report in spring 2016. The future drugs pipeline was the most recent one, but you can see there's some more coming up, and I think engaging with this process as it develops will be a core thing that we'll engage with. The second thing that we'll do is work on the reimbursement model for antibiotics, and a number of these around, some of them within the O'Neill review, some of them in other sessions. There's talk of prize funds. There's others that think all drug-like incentives will work. Various linkaging mechanisms are current thinking, particularly amongst American companies. And then thoughts around upfront payments that could work with delivering a type model of an AML product to market, or a buy after a couple of years of it being on the market, both of which are thinking of payments. And there's also some new thinking around whether we could adapt some models from the sectors that might work. And one that's come to me recently, and I'm just going to take one moment to talk about, could contracts of difference or a cap and collar approach be useful in this space? And if you, I'll go to this this now. I lost a slide. Don't worry. So there are new thinkings like contracts for difference and cap and collar, which is essentially, could we adapt models that used to be used in the nuclear industry for the development of Hinkley Point, something that might work for our sector, and that's some emerging thinking that's happening. With that, I suggest that we go to the first of our three companies, and David Williams, who's the Chief Executive Officer of this, to tell us a little bit, David, of what Discover are doing in this space and where you've got to. Over to David. We are presenter privileges to you, so I hope that you can speak and we can hear you.
I'll go on then. So much everyone. Today. So I'm going to talk from memory here. So we formed Discover in 2009. And at that point, we're faced with here in terms of needing a whole new set of antibiotics for human therapy. And they say that antibiotic research has been quite plagued by difficulty over the last 20 years. It's become clear it's a lot more difficult to discover antibiotics, to discover cancer drugs, and there are a number of reasons for that I'm not going to go into. You don't set up a biotech company to do something easy. If you do, pharma will have already done it and there won't be any commercial reward there. So we, in 2009, raised our money in 2011 and got in 2012. And the thing that we wanted to be able to do to address the fundamental problem in discovering new drugs that is there. It's actually finding the start materials, the new chemicals that you can use to make antibiotics. A number of approaches that have been used historically that have failed. And they failed because there are a number of technical challenges for getting new chemicals into bacteria. This is the problem bacteria that we have in our clinic at the moment, with the gram-negative bacteria. The gram-negative bacteria have cell walls that make it very difficult to get compounds through the cell wall. They have pumps that pump compounds out. They have other enzymes within them that metabolize compounds. So we went with a number of technologies which came together to actually approach this problem and solve it. And it's to say that 5 years ago, none of these technologies would have been possible. To develop them ourselves internally and follow developments within the relative fields out there to enable these technologies to work. Combination of microbial genetics, high throughput microbial genetics, next generation sequencing, and artificial intelligence. And what technologies do is they allow us to essentially see inside a bacteria and see what's happening. Instead of a molecular target and trying to hit it with a chemical and then seeing if that works as a drug, find a chemical that actually stops the bacteria growing or kills it, and technology to see how that chemical's working. Also, importantly, to see if there's any potential resistance mechanisms that bacteria can develop to overcome it. That technology, in essentially all of the bacteria that are a problem out there in hospitals and in the community, of pathogens known as escape pathogens. Both include gram-positive and gram-positive bacteria. So we've developed technology to work with all of these bacteria. And what we've been doing over the last 3 years is an enormous amount of chemical screening, identifying lots and lots of new chemical scaffolds that do something to bacteria and do something in a novel way and have good properties that can be useful as antibiotics. 25 people inside here in Cambridge, but we outsource all of our medicinal chemistry. It's managed in-house, but we outsource it. We outsource all of our efficacy, all of our PK work, and we have a collaboration with Roche in Switzerland. So we've got I think it's about 130 different people all on our programs. But even enough, and we have a lot of chemical scaffolds that we just don't have enough money to pursue. So the ones we are pursuing are going very well, and with our lead programs, and there is a cloak of secrecy of this because we are collaborating with programs are in advanced lead optimization, and what we're trying to do is push them forward to preclinical nomination as soon as we possibly can, and that could be as soon as the end of this year. In terms of numbers, we have a lot of different scaffolds. For each of our key programs, we're working on at least 5 different lead series. Lots of compounds we could also work on if we had the funds to work on them. Traditionally in big pharma and biotech, you find that for every 5 only one will come through to the end. So that's a metric that we use in our program. So we're always assuming that something's going to fall. So I think the approach that we use, and basically seen as typically, is quite a successful one because bypass a number of the key parts of the failure process. You've compounds that work, they get into cells, they're not pumped out, and importantly so, their resistance profile too. At this point, there are a number of that are out there currently that work because they work in more than one way in the cell. So, gyro inhibitors work in gyro inhibitors and topoisomerases, for example. BTAMs work in different classes of penicillin binding protein, and the translational inhibitors work in different parts of the ribosome and elsewhere in the cell. So antibiotics that we have today work because they work in different ways, and because that overcomes or helps to overcome resistance. So actually targeting one specific mechanism inside a cell is going to be successful in the clinic, and we've seen clinical failures that have shown us that. So our approach at Discovery is to work on new molecules that work very cleanly, but to combine them ultimately in the clinic in combination therapies, clean combination therapies, or selective therapies as well. So we're looking at groups of pathogens that work in different diseases. So that we're not developing new broad spectrum antibiotics, and that's really important because broad spectrum antibiotics are problem in terms of promoting co-acquired resistance. In a nutshell, and I haven't had any slides, and I hope you've been in favour of what I'm saying, is what we're doing at Discovery where we are in our program. And I welcome any questions.
Thank you very much for that. I would encourage people, if they've got questions for David, if you know how to drop them onto the chat, we can then pick them up in order, because that's probably the order we'll do it, and we'll reserve questions till the end. So if I may, I'll hand over to Neil Murray, who's joined us here at the BIA, off across London from from some exciting you've been this morning. Neil, I don't know where you've come from, but you've made it in a cab. And I'll hand over to Neil, who's also going to talk about Redex and has a few slides for us. Neil, over to you.
Thanks, Steve. It wasn't very exciting. It was just the city. Good morning, everyone. I've got a few slides here, really just very kind of high-level stuff, just talking about some of the stuff that we're doing in our infectious disease subsidiary. If I can hit the button. Before I start, I have the obligatory, as a public company, safe harbor statement about forward-looking statements. I'm sure you've all read that by now, so I'll move on. In tackling AMR and activities at Alderley Park, there are kind of three things that I want to touch on. The infrastructure that we've developed there. Second is to talk very briefly about some of our program assets. And that is the issue of advocacy. And it's interesting that, you know, just listening to some of the stuff that they were saying there just now, you know, clearly they're involved in this space, they're very passionate about it. But we need to get more people passionate about it if we're going to fix the issue. So I'll touch on some of that at the end as well. In terms of infrastructure, we've got about 50 researchers at Alderley Park within our infectious disease group. We focused primarily around discovery, chemistry and biology. We've got a very strong computational chemistry group. And we also have very good capabilities in DMPK and chemical and bioanalysis internally. Everything that is done in vivo is done externally, and sort of preclinical regulatory tox packages and stuff are done externally as well. That's on looking at existing targets, although we do have a number of novel targets that are under consideration. But around applying the kind of, you know, genetics philosophy, which is how do we produce drugs that are better at hitting existing targets and that we know are clinically validated, and therefore we take away that kind of novel biology risk. And we think there is still a role to play in anti-infectives around that area. A lot of easy stuff has been done. But anybody within the company that hears me talk on a regular basis would know we don't do easy stuff. We focus on the very difficult things, and I've had developed a track record of solving some of these challenges. And specifically, in terms of our programs, we're making some really good progress around diaries assets, both gram-positive and gram-negative indications. So we have a gram-positive program. We're focused on MRSA primarily, and it's a relatively narrow spectrum asset around that. But that's a program that is partnered with the NHS in Liverpool. This is the NHS tell us this is a unique deal. And is one that they haven't looked to replicate. So in this case, the NHS is investing £1 million in supporting this program through to clinical proof of concept. In return, they get a share of future commercial upside on that program. So it's making, I would argue, better use of NHS research budgets. Actually giving them a return on their research investment, and I'll show you some data from that program in a second. The gram-negative assets that we have, again, are targeted at gyres, and we have two programs there, one of which sits within the IMI New Bad Bugs collaborative, which is led by GSK. Program is going well. The one we're progressing internally, and then, as I said, we've got some novel targets that we're looking at as well. The MRSA program, I just wanted to put this slide up and kind of demonstrate that there is life in gyres yet. So this is from a standard mouse model, comparing our compound at various doses against vancomycin. This is really nice data. So vancomycin, as most people will be aware, is gold standard for MRSA. vancomycin here was administered 4 times post-infection and was administered at 110 mg a kg and delivered. Our compound was administered orally. The top dose was 30 mg a kg and was only 3 doses post-infection. And you see here our compound at 30 mg on the right-hand side significantly outperforms vancomycin a logarithmic scale on the y-axis. And we've got very high hopes for compounds from this series that we are looking at taking forwards. The interesting thing about these compounds is the resistance profile is extremely strong. So we've been using these drugs for about 6 months now and have yet to do any kind of resistance mutants to our compounds. And that's largely because they've been specifically designed to have different actions with berries than you would normally see any of the existing classes of compounds like quinolones out there. So the from this program is very strong. We've nominated a development candidate now, and we anticipate that will be in clinic during 2016. I wanted to touch on efficacy because this is very important. If I'm brutally honest, the reason that Red X originally got into infection was because of the cultural opportunity that we felt it represented. We know that there was a significant issue around AMR, and we had to believe that companies were going to come back into AMR because they were going to be not exactly forced, but certainly pushed to do so because of the criticality of the issue. And in saying that, we wanted to be there with assets that they would be looking to license when they came back in. Since we've gotten involved in this space, we've developed a real passion for the issue, and so we spent a lot of time working around the issue, things like the BIA Working Party in AMR. We've had a fairly substantial contribution to the O'Neill Review and continue to do that. We're main movers behind the BioInfect conference, which is now in its 3rd year. A conference focused on the overall global issue of AMR, a one-day conference with an international and a very strong speaker panel, and indeed Jim O'Neill has agreed to keynote the conference for us there. And that takes place on that takes place on Tuesday the 10th of November at Alderley Park and is very reasonably priced indeed. And it's supported by BioNow, who do the organisation of that conference. We're also members of the Beam Alliance as well. I think the key thing for me is, we have advocacy from people around, like cancer or orphan disease. We hear very little advocacy from people in the area of AMR, and that's one of the things that we need to change, I think. We need to get patient stories out there or patients' families' stories out there so that people really appreciate how crucial an issue AMR is for us and what needs to be done to tackle it. So Red X is doing, as Dave said, also welcome any questions, and so I'll hand back to Steve.
And just that you plugged the conference at Alderley Park. It's an excellent event. I was there last year, and I would encourage anybody who's interested in this space. It's a useful day. So third up is Deborah O'Neill, the CEO and Chief Scientific Officer of Novabiotics. That we've unmuted, so please talk, and I hope we can hear from you.
Thanks, and good morning, everyone. So next few slides, I'm going to give you the kind of bird's eye view from Planet Novabiotics in terms of where we can have a role in combating AMR. It's, the reason that we're in existence, coming up with new solutions, first-in-class therapeutics to address this issue. So on this initial slide, I just thought I'd run through some key bullet points and things that we are approaching antimicrobial resistance with very much in mind. And the first one actually is, please don't forget fungal disease. So we have some even bigger storms coming than the issues that we're now faced with antibacterials, mainly because it's a huge issue. Yes, we're potentially facing a post-antibiotic era, but we have many more classes of antibiotics to address those infections than we do antifungals, is an issue that's growing probably even more rapidly. The problems with bacterial disease, and the same could be said for parasitic disease and viral disease as well. So let's not forget fungal resistance, and it's certainly an area that Novobiotics is in. That we need to develop. I would argue we need to stay well away from any Me Too's, okay, and go back to the drawing board. We have, certainly within the SME community and even the academic space, a lot of incredible minds and some really exciting approaches to addressing antimicrobial resistance in completely new ways, and this is what we want to focus on, so the back to drawing board approaches. And really, with that in mind, the potential for coming up with first therapies, so not new classes of drugs that aren't actually that new to the point that they have to be restricted and introduced into clinical practice only when patients are or refractive to other classes. Something that is really at the core of what Novobiotics is doing is the application of non-antibiotic antimicrobials, and this really goes back to the other 2 points above that, a completely different approach to tackling this issue. But as well as new therapeutic classes, there are ways and means to extend the lifespan and potentially even increase the spectrum of activity of the existing antibiotics classes that we already have. So the idea of combination approaches or introducing adjunct therapies that get around the resistance problem of existing classes and mean that we can use those and responsibly for to come. Please also not forget biofilms. Most infections exist in a biofilm state. So fantastic antibiotics, antifungals that address just planktonic bugs aren't very much used. So I think approaches overall that address biofilms and also polymicrobial infections are key. And let's not forget veterinary health as well, and the fact that we need to address food chain antibiotics through novel, again, probably non-antibiotic antimicrobial approaches in food chain animals. In mind, a little bit more about what Novobiotics is doing specifically. So for those of you that don't know, we're based up here in very sunny Aberdeen. It is today, I promise. And the product we're developing focus on the clinically unmet. You could argue that most infections are clinically unmet, but clinically unmet, economically significant infectious conditions. And essentially those where traditional, I would argue, small molecule chemistry has failed. I guess, number one, and especially in the context of today's discussion, is because of a mechanism of action against which resistance is inevitable, safety issues and not ideal efficacy rates as well. We've got 3 clinical stage product candidates at the moment and an earlier stage pipeline, because all of our products come from one of 2 platforms. And as you can see from the chart on the left-hand side, that is an interesting mix of infectious diseases, chronic and acute. So we have some fungal conditions in there, and invasive fungal disease. And in terms of chronic, and especially chronic gram-negative infections, the infections associated with cystic fibrosis are a key focus for us. this concept of non-antibiotic antimicrobials in the first slide, and essentially that's what robotics technology is, and I'll come on to that in the next slide. But a range of antimicrobials for unmet bacterial and fungal infections, predominantly human health, but you'll see from the bottom of the chart we actually have something in the clinic for large food-producing animals and mastitis in those species. The idea being it's a replacement for traditional antibiotics. Animals don't need to be restricted, no as long from the milk or the food-producing cycle, and antibiotics will not be carried on into the game. The big things for us are a mix of chronic and acute bacterial and infections, and in some cases conditions where you have both types of pathogens. I'm in good company here because Redex and Discover and Novartis were among the 37 founding members of the BEAM Alliance, and Steve mentioned, at the outset that to help SMEs in the kind of AMR sphere, and going back to my point as well, I think it's clear from this and what's going on around the globe that the leaps and bounds, I think, and progress in this area is going to come from the SME, certainly not the big pharma side. So we're very glad to be part of this. So on the next slide, a little bit more about the technology that we've developed and how it performs against more traditional antimicrobials. So the first-in-class technology that we developed has essentially come from re-engineering naturally occurring antimicrobials, those which form the body's first line of defense against infections. And, throughout evolution, we have not developed resistance against these. So we're kind of literally taking nature's lead in coming with molecular classes that specific infections and resistance is minimized if not negated. And predominantly these are antimicrobial peptides, but are cystic fibrosis and adjunct therapy class aminothiols. And the key features and USPs over the technology that we're developing versus standard classes of antibiotics and antifungals, primarily how quickly these agents kill. So a big issue and a big factor that can actually lead to resistance is time of kill and checking out not just the balance of infection, but the infectious organisms. Some rapid, potently microbicidal agents that essentially kill on contact, or in the worst case, you have a time of kill that's in minutes, not in hours. The drug target for our technology is the membrane, so regards antimicrobial peptides. That's a big target. The good news is this physical kill mechanism of action that occurs after interaction with the membrane is really what the lack of resistance is all based on. These are essentially very small biologics. They ignore host cells, so they have no off-target effects, no pharmacology against the host cells, so you're looking at antimicrobials with a placebo-like safety profile. In the antifungal world, that's almost unheard of, because normally you've got cell wall components as your target, and then essentially lots of crossover tox with host cells as well. So just an example of some of the stuff we're doing in the TMs on the bottom left of that slide. The most potent antifungal class out there for addressing life-threatening Candida or invasive Aspergillus infections. So, for example, amphotericin B, you're looking at a time of kill of probably 8 hours plus, at multiples of the minimal inhibitory concentration. What you see with our technology is within minutes, it's carnage. You can see cellular lysis, and within 15 minutes it's essentially all over at 1 times the FTP. So very rapidly acting, safe antimicrobials. The spectrum of activity of these, there's an example of this on the top right in the untreatable bacteria, available targets for this. So 2 of our compounds, MP108 and MP432, are potently active against A. baumannii, affectionately nicknamed Iraqibacter, so a bug that's essentially inherently insensitive to almost all known classes. And apologies that the text is very small, but essentially what you can see is in that panel that kill happens incredibly quickly, again within minutes, to prove that the membrane's the target. If you include an agent that prevents the charge dependent antimicrobial membrane interaction, you switch off activity. Yes.
Steve, I'm afraid we're getting to the end of your time, so I'm going to ask you to bring this to a conclusion, and I do have a question for you. Absolutely. So, yeah, I mean, the conclusions are in the teal panel. So, focusing on treating but also preventing infections with these non-agents, a bacterial, fungal and polymicrobial sphere, acute and, please don't forget, chronic infections. For us, that's cystic fibrosis for sure. And as well as that, looking at extending the lifespan or utility of existing classes. So with our CF component of X, we can reverse antimicrobial resistance against the standard CF antibiotics. Biofilms always have to be a target that you need to keep in mind, disruption and prevention, and then finally, alternatives to the food chain antibiotics. Thank you. The question that we've got on the chat for you is, with respect to biofilms, is Novobiotics considering disinfectant or sterilization actives? No. So we're focused very much, rather than on biocides, on medicinal products. Okay, that answers that one clearly. So now we here try and make sure that we can speak Colin, because we're not sure Colin which callers you are. So other calling users, please speak quiet while we unmute Colin. Colin, if we ask you to hi, maybe we hear you, Colin. While you're on the line, so next up is Colin from Antimicrobial Resistance Chapter. You control, Colin, so it's over to you for an update from the charity perspective.
You can't see my slides up on my screen. Good morning, everyone.
We'll take back control, and I will lead you through. I will walk through the slides from our perspective. So, I'm seeing the first slide.
Thanks very much, Steve. Good morning, everyone. Just very quickly, Colin Garner, Chief Executive of a relatively new charity, Antibiotic Research UK, just last year, and we're just reached 12 months. Next slide, please, Steve.
Yep.
So, mission to protect and promote the health of the public, in particular by sponsoring research into diagnosis, treatment, and cure of antibiotic-resistant bacterial infectious diseases. Next, please.
Yep.
As Steve mentioned, we're very proud to have been nominated as BIA's charity for 2015, and the successful funding event at the gala dinner, for which we're very grateful. Next. Everybody's seen this slide, but this is from one of the O'Neill Commission's reports, estimating the likely mortality associated with antimicrobial resistance by 2050. And, basically, we're talking about a large number of people, 10 million or so deaths per annum, and the economic costs somewhere between 60 and 100 trillion. So a problem, as everybody on the call today is aware, needs tackling, and it needs tackling now. Next, please. The was formed out of a network of both academic scientists and also representatives from specialty pharma companies. That network was called Antibiotic Discovery UK and was founded by Professor Anthony Coates. And mentioned we were registered last year, and first AGM was in August 2014, and next AGM is here in York in August 2015. We'll be sending Steve invitations for people if they'd like to come and hear about what the charity is up to. Next slide, please.
Thank you.
So, where we are, we've constituted ourselves. We have a board of trustees, an audit committee, our executive. We have a very heavyweight science and technical advisory committee, which I'll talk about in a moment, and we will have a finance raising or fundraising committee. Next, please.
Yep.
These are some of the people involved with the charity, and I'm sure many of you will recognise both their names and faces. Woodford, I think, is probably well known. Coates, also well known to everybody. We're a mix of pharma representatives, biotech representatives, and representatives. And one of the thrust of charity is to try and collaborate across all sectors interested in antimicrobial research. And we are raising money to end. Next slide, please. So we take the view that in order to tackle this problem of antimicrobial resistance, we have got a great deal of time to perhaps be investigating new chemical entities, because it may be another 10 or 15 years before they are available and on the market. So we decided to focus very much on what we call antibiotic resistance breakers, compounds that might overcome resistance of existing antibiotics. We feel they might be able to provide a stop measure until NCEs come along. Next, please. So, antibiotic resistance breakers, we have decided to investigate the most intractable of the species of bacteria that we want to try and treat. We're talking about hospital-acquired infections and gram-negatives. We did the four most common negative species for investigation. We'll only screen against antibiotic-resistant strains, and are the antibiotics we want to focus on: carbapenems, fluoroquinolones, aminoglycosides, and polymyxins. These are the ones, of course, where antibiotic resistance is the most common, and where we are fearful that the problem of resistance will become larger. Next, please. To tackle this problem, we are trying to raise money from companies, individuals, high net worth individuals. Our target is to raise £1 million in the next 5 to 7 years, and we're hopeful that within the next 6 months we will be able to start some of our initial programs, which in all probability will be carried out in university academic departments. We're looking to collaborate with some of your member companies who have perhaps screening facilities that we might be able to So that's pretty much it at the moment, and thank you for your attention.
So now it's time for any further questions that people have to any of our company or Colin from our charity. I'm going to unmute Ben Sykes from BSRC, and Ben, I'm going to ask you to comment on some research you've got going at the moment.
Thank you, Steve. Ben Sykes here from the BSRC. I put some on chat through to Steve just in response to this presentation, and specifically around biofilms. Just in companies online are not aware, BSRC and Innovate UK are partnering right now on a general research call on biofilms, and there's a CR&D call out in feasibility studies at the present time, which closes in September. So this is funding for both industry and academia, preferably working collaboratively together. Steve, I just wanted to highlight that for everyone's knowledge.
there's always fantastic stuff done by Ben and the BBSRC. It's always worth a look, and lots of people have got lots of useful stuff from the fabulous work that the BBSRC do. So do take if that's up your street. Any else questions-wise on chat? If we'll risk opening up everybody to demuting, and if we get a lot of noise, then I will have to shut you all up. But everyone's open now, so any questions from anybody on the phone?
Could I could I just come in on one general question for three company speakers? What do they see in academic collaboration in business? Typically that's work funded by research councils.
So the question is, what value do you see in academic collaboration in this space? And I'm going to turn to Neil, who's next to me on that one. You talked about your collaboration with the NHS, Neil. Do you have similar things with the universities?
Yes, we do. We've got going on with a number of universities that are active in the space, and indeed another academic clinician just 2 days ago about a new collaboration with Manchester. So that's something that we see as a very important part of this. I think one of the things, if you're a small company, one of the key things is to accept that you don't have all the answers. And if we can tap into, whether it's the NHS or academia, access to expertise that we don't have internally, then that's got to be a smart way to do it.
Thank you. I know that you have collaborations with some of the world's largest schools. You also reach back into the academic community in the UK?
This is talking to Ben with privately on chat. We find there's been an enormous lack of funding in the academic sector, and it's also an empty well in effect of talent. That's changing. We're starting to see the new shoots of young, bright young things coming into the area. But it's quite honest to say out and push this out there. But the standard of the science in academic labs in the UK is not very high, which is why I'm so excited by this charity. A bit less that they want to do drug discovery, but excited that they could be another source of funding for academic labs to really bring them up to the standard we are in cancer research and viral research, for example, which have had enormous amounts of money pumped into them. We have some fantastic science in the UK. So if I have a want, it's to be able to turn to the academics to do some really good basic science, because we're discovering an enormous amount of new science, an enormous amount. And, go back to the literature and we try and find out the backup on this science, and there's nothing there. Just nothing there. We don't even know how a bacterial cell dies. I mean, it's that much knowledge is missing.
This is Colin Gard to say something about that. You're right. I mean, our charity is indebted to academics working in their area. I think that's very important, because we do need youngsters to be coming through work in biotech and pharma companies and in high caliber research labs. So certainly one of our goals is to try and improve the academic science in this area, and we have been asked on a number of occasions about whether we will support basic science, and I think the answer is yes, we will. Ultimately, it's all in the end down to how much money we can raise.
Do you have views on the question from Ben about academic collaboration?
We certainly, at a practical level, do collaborate. We have one of the best fungal groups in the world here in Aberdeen, but slightly further afield. But I also agree with David that's a two-way street as well, and I think it's great for both sides. So for us to tap into tools, some expertise that they've got, but also aligning what academia are doing more with what's required at the drug discovery stage. And to Neil's point as well, I think an essential component of collaboration is with clinicians, not necessarily the NHS directly, but certainly in terms of steering clinically appropriate activities. So I'd say that the best form of collaboration would be the clinical world and bringing academia more and more into that.
Thank you. We've done 50 minutes of time. We said we'd do around 40, so I think I'm going to suggest that we bring this to a close now. We'll thank all of our presenters for making the time and a whirlwind around the country for what's going on in AMR. I hope you found it useful. I think the thing that I'd like to do before I leave you is explain to you some of the things that are from the business perspective. We've a webinar, if you're not away, in August on innovative medical technologies and services transforming the medicine of tomorrow. In Biotech Networking Evening on September the 9th in London. A genomics webinar on September the 17th I'm looking forward to, and we'll be having at the Stevenage Bioscience Catalyst in September the 24th. Looking to your diaries, our big event of the autumn is the UK Bioscience Forum and Autumn Reception in London on October the 15th. Then we'll more webinars and breakfasts, Nottingham, Manchester, and CEO dinner on November the 18th. Bioprocess conference for those interested in the manufacturing side of things at the end of November 25th and 26th. So I see there's a broad set of events coming up. And if you are interested in the gala dinner, we are launch this formally in marketing terms very soon. There is the opportunity to reserve your table today. 65 tables are available. We've sold 23 before anybody's actually marketed this. So if you are interested and you want to be front, do tell us now. Neil's raised his hand, so that is one booking, and Harry's happy to take bookings. If there's anything else, I'd just like to thank you for joining us today. If you're interested in this for colleagues, a recording of this will be available on our YouTube channel, and perhaps you can share with those who are on holiday. If there's anything you think we should do to improve this, we would welcome your comments. This has been a new format for us today, and I hope it's been useful. With that, I suggest we close, and thank you for your time. Thank you.
Thanks, Steve.